conference will now be recorded.
All right, let me back up because we definitely want to make sure that we include the sponsors in our opening message. Whoever started the recording late, they would be Novartis, Telex, Blue Earth Diagnostics, and Foundation Medicine. And we thank those people. This is the AnCan Active Surveillance Group for people that have been newly diagnosed or on the AS journey for a while. We don't speak about treatment, so if you've had treatment or being treated, we have groups that fit you better, but you're more than welcome to stay and listen if you like. But as I said, we don't discuss treatment in this group, but we are the BPH group. So if you have been diagnosed with BPH or think you have it because you get up like 5 or 6 times a night or whatever, this would be the group to try to open up the discussion. We have people who have undergone treatment for BPH. In fact, we have someone that wants to discuss it this evening. So without further ado, I'm going to let Olu, he patiently waited last week.
Would you want to do the new guys first and then do Olu?
Well, you made it a point that you wanted to, he waited patiently last week. So we'll give Andy and Lieven a little bit more time to get to their.
Sounds good.
We'll let Olu take the floor. Go ahead, Olu.
Thank you. Mine is going to be really brief. It's just in regards to 2 sessions ago, in regards to finasteride, me trying to get off of it. So I have a meeting coming up in March with my urologist, and I wanted to find out if there are any suggestions based on some of the feedback I received 2 sessions ago in regards to some of the long-term side effects of finasteride. It's really worked for me, but so I'm looking to see if there are any suggestions or the types of drugs I can discuss with the urologist in March when we meet in regards to that.
Okay. I myself don't take anything, so I'm at a loss. Dr. Dan, can you maybe help out with that?
Are you taking it for BPH problems?
Yeah, for BPH, I've been taking it for about probably maybe 2.5, 3 years now. It took a long time to start for it to start working, but when it started working, it was really working. And yeah, so about 2.5, 3 years now.
So Olu, when you've been on finasteride, have you had some MRIs that have shown your prostate shrinking, the volume when they?
That's where I'm kind of because even though it's working, I've had 2 MRIs, and there doesn't seem to be that much of a difference in the size of the volume, etc. However, the first MRI that I had, it showed the prostate pushing against my bladder, and then kind of forming like a, I don't know, like a pouch on each side, and then a narrow thing in a narrow place in the middle because it's really pushing against it. And the second MRI, it showed that the prostate has receded from pushing against my bladder.
Well, that's why it's working. Yeah.
Yeah. So the first I'm trying to get to the first MRI I did.
You know, here's the deal. You know, we don't have to fix this if it's not broken. There's nothing wrong with finasteride. It's a good drug. As you said, it takes 3 to 6 months to start working, but once it works fine. It does have some side effects. It does cause low testosterone. It does reduce muscle mass. It does reduce libido. And I guess it probably could also cause erectile dysfunction. But if none of those things are bothering you and it's working, the only real downside is that it makes it hard to follow your PSA, you know, for your prostate, for your active surveillance. And that's one of the only 2 data points we have, that and the MRI. So I hope we didn't say something here that made you think like, you're doing something wrong. You should get off of it. But because, if you stop it, you're going to start having symptoms again. You're not going to sleep well, and you're going to be getting up to pee all night. And so, and the only real, the only other drugs are what they call alpha blockers, like Flomax, which work right away, but aren't as probably effective as finasteride. But I don't, I think if it ain't broken, we shouldn't necessarily try and fix it.
The only concern was when it was said that, studies have shown that people who take it often, develop high-grade cancer. So that was the one that stood out at me. And
yeah, that thing has been floating around for years, and they've gone back and forth on it. And my understanding is right now, there's no real convincing evidence that the cancers people get on finasteride are higher grade. As I think Rick explained, if your prostate's smaller and you're having biopsies, I think it makes it more likely that you'll hit some tumor. But I think that the whole theory about people on finasteride having more aggressive tumors is I agree. It's sort of in limbo right now. And I don't think it's been proven to the point where you want to necessarily change your regimen. The other problem is if you decide with your urologist that you want to go off finasteride, and you've already tried and failed on alpha blockers like Flomax, then you're really looking now at some surgical type procedures, which, it's not like a minor deal here. So I think this is a decision that, if you're doing all right on this, I don't think we should fix it if it's not broken.
He's going to say
my first MRI, the prostate was 76 cc. It's a bunch of numbers. It's a 6.1 centimeter TV by 3.9 centimeter AP by 6.1 centimeter CC, and then volume is 76 cc. And then the MRI I did, that one was June of 2021, and then my next MRI was April of 2023, and the volume there, actually it was 81 cc. And then the one I just did this November, November of 2025, it was 79 cc. So, well, actually, there are two numbers here. Prostate measure, volume 86 cc, and then prostate volume calculated in DynaCAD prostate boundary segmentation 79 cc. So,
Well, even though it looks like the numbers aren't concurrent with getting smaller, you said your symptoms got a lot better. So evidently,
oh yeah,
evidently it's like Dr. Dan says, it's working. So
yeah.
I don't know what decision, which talk it over with the urologist and see what he says. See if he comes up with any viable options. What he would think.
Okay.
Would he go with the alpha blockers or whatever, and be sure to get back to us? I know Ray has his hand up. Go ahead, Ray.
I was going to say, and I certainly, if finasteride's working, I don't think I would try that. Well, unless you decide to go off of it, but it's an over-the-counter life extension saw palmetto betacisterol product called Prostagard, which has worked well for me. But my prostate's half the size of yours. So it various times people, different urologists have said, well, it's close to the bladder, and that's why you're going so much. But for whatever reason, it seems to work for me. Now I'm told I just have an easily irritated bladder. So, for whatever reason, it seems to work works for me. So I don't know.
I'm
if you tried
surprised we've never had discussions about saw palmetto in here, because it's probably the most studied over-the-counter nutraceutical, and it's probably one of the only nutraceuticals that actually has really good, placebo-controlled, randomized trials, and they have pretty consistently failed to show a consistent effect of saw palmetto on urinary symptoms, on urinary size, on voiding symptoms, what they call LUTs in men, lower urinary tract symptoms. However, if every urologist will tell you he or she has a few patients that respond to it. So it's kind of a weird deal, but I would say the only, Olu has a prostate that's right on the borderline. Around 80 cc's is when they start disqualifying certain of the surgical techniques for it's what 80 is sort of what they call a big prostate, and that sort of doesn't respond to some of the less invasive technique, surgical techniques. So I guess the key thing, Ola, would be for you to tell your urologist, if you're tolerating this stuff well, your libido's okay, your muscles aren't disappearing, and then, like I said, I'd be, I wouldn't fix it if it's not broken.
Okay.
If you're concerned about the research, Olu, I would get on PubMed and do a little research on your own to see what the hardcore research is. One of the things you probably hear throughout all of these is there's a lot of fake back and forth, and specifically related to more aggressive cancers. I mean, it is fairly common knowledge that grade group 1, pure grade group 1 doesn't, it's relatively low potential for metastases, but sometimes when you see it more aggressive cancer, it's because grade group 1 was misdiagnosed at the beginning. And that's just because you just can't sample the whole prostate with a biopsy or with an MRI. So do your research and do some comparison, and then talk to your urologist, absolutely, if you're concerned about it.
Okay, thank you.
Okay, anybody else have anything for Olu? All right, before we move forward, Dr. Wayne Greaves joined us. I'd like to say hello. Wayne,
Hello.
how are you? Do you need any time this evening, sir?
No, thanks. I'm good. Good, Gary.
Okay, good to see you. All righty. Okay. All right. Well,
Right.
Andy, you're gonna be up, so I'm gonna turn you over to Dan.
All right. Well, welcome here, Andy. First question. I mean, we know where you are in Boca Raton. How did you hear about AnCan? What brought you to us?
I think Prostate Cancer Research Institute made a mention.
Okay. And we do have your email, correct? Because you got an email reminder. All right, so that's good. How old are you, Andy?
78. He's 79 in about a month.
Okay. And are you a veteran, perhaps?
No.
Okay. All right. When were you first diagnosed?
The biopsy was done October 20th of 25. Results came back on the 27th. That was from Delray Pathology locally. They did me at a 3-4. I had a left lateral apex, which was shown on the MRI only. But in the biopsy, there was a right medial apex, 5% on both, which was good news. Those are the only two samples that came back, the only two blocks that came back positive for adeno. So I sent it to Epstein, and he said, for the life of me, don't see a 4. So he rated me at a 3-3, group 1. So I said, okay, that's good news.
Yes.
So I found out my sister had an ATM mutation. So I did genetic testing and I was negative on that. And I asked for a PSMA PET scan before I did any treatment. The urologist recommended radiation. So this is with a 3-4. That was with
he
3-4.
radiation for what?
Yeah.
Well, I had a 3-4 at that time, and he felt radiation therapy was indicated. So needless to say, he's no longer my radiologist.
There you go.
Well,
There you go.
that's a
One
good
score for
move.
Andy.
And let me just make something clear. You had a 3+4, and in both cores, they were 5% was 4?
Yes.
Is that
Yeah,
right?
they're both 3 + 4 is 5%. Correct.
And this guy wanted to give you radiation. Wow.
Yes. And
Incredible. Still going
I
on.
followed up with the radiologist, radiation oncologist, met with him for about an hour. I'm a critical care nurse practitioner, so I have some knowledge of medicine. But, you know, it's like if you go to your intern and you ask about your eye, they don't know anything about it. So the prostate was the same. I knew where it was, what it did, and the basics, and that was it. So it's been a lot of review. I didn't want to overkill it, but I did want to learn what was going on. So I spoke with Epstein at length, and he said, I just don't see it. And I asked him why.
Well, good for you.
And he said, knowledge and experience. I mean, he is the man. So, you know, that's why I went to him. And the MRI, I had that read second opinion also in Philadelphia by a friend who's a neuroradiologist, but he's a specialist in MRIs. And what I found interesting is the MRI only showed the left, did not show the right. So what my understanding was that it's sort of like it lays in the weeds, and that's why you do the biopsy. Because it can be underneath where the MRI cannot see it. Now, the urologist who did the biopsy did a transrectal, unfortunately, because I know you don't see the anterior with that. And, you know, my concept of sticking a sterile needle through my rectum with stool into my sterile prostate does not sound like a great idea. At any rate, that's what I had done. And what else? So the PSMA was good. The Decipher was a 0.3. I did see a medical uro-oncologist, and he felt he didn't need to see me anymore, but he would be there for any assistance that I might need. So in January of 25, my PSA was 1.9, which is what it kind of normally was, you know, 1 to 2. In September 15th, it was 5.4. 15 days later, it was 7.6. That was when I was at the urologist for my annual checkup. So he said, we need to do an MRI because it was such a precipitous rise. I know it didn't hit the 10 scale, but it was precipitous enough to do something. So we went through with the biopsy, and then I had the PSMA. I think that's pretty much all the diagnostics I've had. It seems to me that prostate cancer is one of the most difficult to treat because where it is, and it's like we have a pie, and all these things I found out technically, that's like 1/3 of the pie. The other 2/3, everyone says, well, you could do absolutely nothing and live to 95 and never die from it. Or you could metastasize in a year, but that's unlikely because you have a slow growing adeno and you have a 5% and so on. So it's like the information at that point after all the diagnostics come in is kind of up to us. You know, what we think based on going to the people who have the knowledge and experience to explain how it all works and why, if I'm comfortable enough with it, active surveillance is good. And I'm all for active surveillance, at least for the year, and see where it takes me.
So how are you mentally? Where are you at?
Initially, you know, the only difficult part was, oh shit, I have cancer. You know, that was like the hard part. And over time, I just sort of feel like, okay, I have all this information. I'm comfortable with the information, what it means for me. And I'm comfortable to take it 1 year at a time, basically, at this point. I have a good urologist now. The biopsy that I would do next will be transperineal.
Yes.
So I'm glad for that. We're doing PSAs every month. I guess he'll MR me. My MRI was, when was it? It was like maybe it was September.
So you're seeing who are you seeing? Who's taking care of you from your urologist? You said you're in Boca and you went to pathology.
Dr. Joshua Hyman.
Where is he out
He's
of?
here in Boca Raton through the Lynn Cancer Center.
Okay.
Is he your new guy?
Pardon?
He's your new guy. You got rid of the other urologist?
You want to know who that was?
The bad guy? Yeah, we want to know the bad guy too.
Yeah, his name is David Schwartzwald. He's been in Boca Raton for I mean, I've worked with every doctor in this community, around the state, around the country. I mean, I do life care plans. So I have a lot of anecdotal communication with physicians. And he had a good reputation, but nope. Plus, he wasn't calling me back. Dr. Hyman, we did a PSA. I sent him the result. He called me to tell me, oh, this is good news. By the way, that was 1.9. That was a week ago. So it's very possible I had prostatitis when I had these elevated PSAs.
Yeah.
It wasn't reading any kind of cancer. But
And
fortunately for me, we went through the biopsy, the MRI, and now I know, and it's such a small amount. So, you know, I have it early.
And you're going to be 79
Correct.
shortly. So if you're 79 and you don't have any degree of prostate cancer, that to a degree that's almost unusual. I mean, if you're at 80, you get about an 80% chance of having prostate cancer. So not completely unanticipated. And we got some folks with their hands up. So I'll pass it off to Dan first.
I guess I just wanted to clarify with Andy. So you said the MRI did identify the lesion on the left, and was that targeted in the biopsy, or did you just have systematic blind biopsies and they didn't go after a particular lesion?
I had a focal targeted biopsy.
Okay, but you also had a systematic biopsy because they got stuff on the right side that didn't show anything.
Yeah, he did 13.
Right. Okay.
13 sticks.
Yeah.
And
so
Dr. Hyman, go ahead.
Yeah, I just want to say about that. You were saying about the MRI as if it was sort of a failure of the technology.
No.
MRI is, everybody knows and recognizes MRI is not good at seeing low-grade lesions.
Right.
And it's not, I mean, it would be nice if it could, but you know, low-grade lesions are probably not going to kill you. So it's probably less important that it sees those. And however they've arranged the technology, they will be the first to tell you that it's not great at seeing your 3+3 lesions. And so.
Right. Yeah, I understand.
And also, you said you were getting PSAs monthly?
No, every three to four.
Oh, good.
Be 4 months this time. Since I just started, basically.
And since you're new, I'll ask you the question that everybody gets asked. You know about all the do's and don'ts of PSAs, what to avoid prior to your test?
Yes, I do.
Yeah.
Hey, go ahead.
Did you say you had a PSMA PET scan or you did not?
I did.
You did, and what did that show?
I was
Nothing?
negative. It just showed
Yeah,
the normal
okay.
hotspots.
Yeah, it's so.
Because I wanted to make sure, because of the radiation, you know, and it was sort of a learning curve at the time. I said, okay, I'll speak with the radiation oncologist. And I spoke with two, because the first one, when I asked about the barrier gel, he just blew that off. Like, oh, no one does that anymore. And I thought, what? The latest data shows everybody does it. If you can, you should. You know, yeah, it might be uncomfortable. So the new one, just as an anecdote, have any of you ever had a prostate exam in the stirrups? Okay, I did for the first time in my life. And it was much more comprehensive because in the stirrups, they can get almost to the anterior portion of your prostate. And believe it or not, it was done by the second radiation oncologist of all people, not the urologist. And, you know, it wasn't any less or more painful. In fact, I think it was less painful. Maybe that position is better for that, but
Well,
I
that's
just thought that was kind of interesting.
well, when you do a transparent needle, that you're in that same position.
Yes.
Yeah. Rick, go ahead, Rick.
And what was the PIRAD of the lesion that it did show on the MRI? Did they give you a PIRAD score?
I think it was a 3-4. Let's see. MRI. Okay, the PIRAD. It came up with a 3-4, suspicious lesion, tissue sampling advised. That's why I was pleasantly surprised when Epstein came up with his 3-3. Have you guys watched his lecture on November 25th that he did?
Yeah.
You did, Phil? Yeah, I mean, he showed cellular structure.
Yeah.
And explained why there's different 3-3s even. And I found that really fascinating. And, you know, I'm a 49.2, that's the size of my prostate. So even with my highest 7.6, that puts me at 0.15.
Yeah.
So that's good too. I tried to look at all the aspects that I could to feel as comfortable as I could about my decision.
Rick?
What kind
of have you worked with Dr. Poonen or not? You mentioned you know all the doctors, so I wondered if you worked with Dr. Poonen.
For which doctor now?
Urologist.
Sanjay Poonen in Miami.
Hold on.
He couldn't hear you, Rick.
Yeah, no, he heard. Dr. Poonen.
Oh, he
have
did?
you worked?
Right.
Have you worked with Dr. Poonen, Andy?
No.
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 Well, we consider him to be by far and away the best urological oncologist in Southern Florida.
Okay.
And he is very well disposed towards active surveillance. So if we have any men who are sort of on the edge, should they get treated, shouldn't they get treated, we will suggest that he is their quarterback. Have you worked with anybody at Sylvester?
No, not for this. But I'm not on the edge about AS. I mean, I'm totally convinced that this is a good way to go at this point.
Well, but you want what you want is it sounds to me, and forgive me, I came in late, but it sounds like you want a good quarterback doctor for your prostate, right?
Absolutely.
So if you want a good quarterback doctor, and have you had any? You've had no treatment to date, correct?
Correct.
So then it's going to have to it's going to have to be, or it should be, with a urologist. There are some exceptions like Hugh, but they're very, very rare. It's got to be with a urologist, hopefully a urological oncologist, so a urologist who specializes in cancer.
Yes.
And if you're going to be with a urologist who specializes in cancer, in our view, you definitely want to be with a center of excellence and not with a local practice, which you are now. And we're aware of a bunch of different urologists in your area, because we have people in Boca, and we have people up and down that coast and all the way down to Miami. And the best doc in the area, in our view, is Sanjay Poonen. We'll put his
I'll check out.
We'll put his email in there. But it sounded like you haven't found a doctor, that you're dissatisfied with your doctors. I'd say go to Sanjay Poonen, go to Dr. Poonen, tell him you're an AnCan person, and I think you'll be very, very happy.
All right. I appreciate the suggestion.
So we've got one more new guy and several other people that need time. So unless anybody has an urgent question for Andy, we'll need to move on to Lieven.
I have an urgent question for Rick. Rick, speaking about referrals to, top-notch guys, I've heard you say very, very nice things about Peter Carroll at UCSF. And I've had a lot of trouble getting a straight answer from the urologists and the uro-oncologists I've seen about AS in patients who are BRCA1 carriers. And I thought I would ask him, since that seems to be one of his interests. But man, they've got that guy locked up tighter than Fort Knox. And
so I'd rather. I'm happy to answer it. I'll be here the whole meeting, but let's go. If you need time,
okay. We can talk later.
Let's go in the order that the moderators are going, and then I'm very happy to come back. But
Okay. All right. Thanks.
I've just got a real quick question for Andy. What was your last PSA number?
Last week it was 1.9.
Okay. All right. That was my question. Okay. Anybody else have a question for Andy, or we're going to move on to Lieven?
No.
Okay.
All right. With that, even you heard the questions that are going. You kind of have an idea what it is that we're doing. So let's move to you.
Yeah. Can I just check? Do we have Andy's email address in the database?
Yes, we have that.
Yes.
Thank you.
Okay. Great. Thanks. I'm a little overwhelmed because I'm not sure I'm going to be able to give all the details as well as Andy did.
That's fine.
But so my initial, I had a raised PSA to 4.3 in October 2024. Then did an MRI. There were 2 PIRATs 4 regions, both in the apex, right and left. I think posterior, left posterior.
Okay.
Right and left posterior in the apex. And then a biopsy was done, so a kind of a combination of targeted and systematic, with 12 targeted, 17 systematic, so 29 cores. 2 came back with cancer, 40% and 60%, and then 10 and 20% 4. So it was Gleason 3+4. So the urologist then recommended radical prostatectomy. I panicked. I went to some of my Belgian friends, showed the biopsy report, and said, "Hold on," and they said basically, "Hold on for a second." You know,
Good
it looks
advice.
like, you know, sometimes the pathologists can disagree on what is 3+4 versus 3+3. So why don't you, you know, kind of come here to Belgium, do another MRI, and do another biopsy. I have, in the meantime, done that. I had another. So my first biopsy was December 2024, and I just had another biopsy just now in January, early January, after having done an MRI in September 2025. A second MRI.
Was your most recent biopsy, fusion biopsy, targeted using the MRI?
So it was also a combination of targeted and systematic. And so similarly, it found, so good news, bad news. They didn't find any 3+4. It was all 3+3. But they did find 5 out of 19 cores 3+3. And my recent PSA is actually now 5.3.
So with the 5, you said the five cores were, how many of those were in the targeted location?
I think it was maybe only 2. Yeah, but I think, you know, I can't really. She didn't really specify what she did. To me, it looks like it was mostly systematic, and she had just 2 or 3 in the targeted area. That's how I'm seeing the biopsy report. And so, but it was 3% cancer. So I think they just calculated the overall length, and so yeah, 3% seems low, but it was 5 out of the 19 cores were positive.
So do you live in Singapore?
I live in Singapore, but I still have a base in Belgium, meaning my parents are there, and so I have a hospital that I go to there as well. Yeah. So I've been kind of trying to do both because I feel like, you know, after this first panic, I was really kind of surprised that I was almost going to have this prostate taken away, whereas after a second opinion, it was, oh, hold on, you're a very good candidate for active surveillance. And that turns out still to be the case, I think. Because I also had the Decipher test done. I'm at 0.22. And here in Singapore, they also have something called the Artera test. I don't know if you've heard of that, Artera AI. Similarly, it's low. So it was concordant.
And how old are you leaving?
So I'm 57 now, turning 58 this year.
Okay, so a little bit young.
Yeah.
Okay.
And so I was, you know, I'm on leave from work right now because I actually decided to try to handle this because I'm, you know, as you can tell, I'm still a little bit concerned.
Yes. Yeah, understandable. Well, I mean, some of the standard stuff that we would ask you as to where you're being seen and your doctors don't necessarily apply here, since you're between Singapore and Belgium, unless Rick knows some people in either place.
Let me, maybe one detail, I am planning to move to the US, to San Diego. And so my wife is US citizen, I'm a Belgian citizen. We're applying for a visa for me.
Okay.
And my daughters are there. One of my daughters is in San Diego, the other in New York.
Well, if you go to that area, then things change significantly. We've got several of the guys here that are from the Southern California area, and there are several good doctors in that area and good places, centers of excellence that you can go and get treated. So one of the things, since you're still a little, and we got a couple of hands up here, so I'll turn it over in just a second. But one of the things that you should be you should have some peace about is if you've got time, you don't need to be treated right immediately. So your friends that gave you advice that said, hold on a minute, those are good friends. The doc that wanted to take your prostate out, or he's not your friend. So stick with the people that are saying, hey, hold on. Many of us here, in fact, all of us here have been through that same situation. There are guys on here that have been of active surveillance for a long time. We have guys, he's not here tonight, but he had 11 out of 12 cores positive. So he's a high volume guy and he's still on active surveillance. So you have time. Time is on your side. And what you want to do is, so the things that you're doing right now, first good thing is getting in with us. And how did you hear about us?
So I started researching what to do, and definitely kind of support groups came up, and then I started researching, and then I think it was ChatGPT,
Okay.
finding AnCan. Yeah.
Okay. Do we have your email? Did you sign up for any of the reminders?
I don't think so. I don't know how I can easily do that.
If you would put your email address in the chat window, we'll make sure that you get reminders for the meetings. And I know it's not the most conducive for you probably in Singapore time-wise, but
this meeting time is perfect, but if it's others.
Well, this is consistent. We meet every Wednesday, first to the fourth Wednesday at the same time. The fifth Wednesday we don't. So if there's a fifth Wednesday in the month, we don't meet. But you've got a wealth of expertise. I'll let Gary talk because he's got his hand up. He's patiently waited.
No problem. I was going to just reiterate what you said about people having high volume 3+3 6. We've got a guy 11 out of 12, and he's been instructed not to worry and proceed on the course that he's at. There's more than one with the. I don't even know if you had how many cores did you have initially?
29.
Yeah, that's a bunch. So 5 out of 29 or whatever, or maybe that wasn't the one that they've got the 5. It would.
So it was the second one that was 5 out of 19. Yeah.
Okay, still not considerably over high volume, and real important what Dan said. Time is definitely on your side. You've got time, hopefully, maybe to come to America and be closer to your daughters, and then we have a wealth of information and people that can really help you out. You heard the other person, Andy. Second opinions with a Dr. Epstein, for pathology would be absolutely fabulous. But for you to figure that out from Singapore might be a real hassle. If in the, near future, near being not really determined, you make it over, to us, then that becomes a piece of cake. And you have a wealth of information will be at your hands. So that's all I wanted to say. But please come back and let us know what's going on and join us each Wednesday. That'd be fabulous.
Ray.
Okay, Ray.
Did you have any genomics of your tumors or genetics, like for any of the BRCA mutations, any of those tests done?
Well, other than so I did the Decipher and then Artera EAI, yes.
What was the Decipher?
Sorry?
What was the Decipher score?
0.22.
Oh, okay. Yeah, no, it sounds like you've got low. I mean, that's low grade. That's very good. So, and did you test for any of the gene mutations at all, or?
Well, not and so I was. Is that not part of what Decipher does? Do they not? Will that be somewhere buried in the report, or do I have to do that separately?
No, the Decipher is the DNA of the actual tumor. The genetic is actually is a saliva test, and they're testing your DNA to see if you've inherited anything from your parents. to see if you have like the BRCA mutations, which is also for breast cancer in women. So it tests for about, I think it's 18 different genes for mutations too. So, but
Do you have
it's
any
very good
family
you're able to study for 0.22.
Any family history, Lieven?
My grandfather on mother's side died with prostate cancer, but it didn't kill him. Yeah.
Okay. Okay. So he died with it.
Yeah.
Rick, go ahead.
So I am surprised at you guys that you haven't brought this up yet, but you're not our first Singaporean in this group.
It burned.
We've had a Singaporean in our group for, I would say, 2 or 3 years. He just finished treatment this week. 3+4.
Oh, Burns.
He went for a long time thinking, should I get it? Shouldn't I get it? And then his cancer got closer to the edge and he got worried, and he did all his homework and he went here and there and everywhere, and he finished up getting treatment at Stanford, and he just got done last week. He's a super guy. He's an artist. He spends half of his time in Singapore and the other half of his time in on the peninsula in Northern California. When he's not lecturing in Fiji or Toga or wherever it is he goes, I don't know, Bali, I think.
Bali.
We've seen Komodo dragons wander in front of him when he's been on here. He's a character. I have sent you a private message with his email. Strongly recommend you reach out to him. He's become pretty knowledgeable, and we love him. He's a really good guy. And in fact, we're going to do an interview with him on, I think, March the 25th in our Solo Arts Heal series. So, yes, so I want to make sure and connect you guys, and then we'll have 2 people, and who knows, maybe we're starting a European AnCan group this week. So actually next week, the 18th, we're starting it. We're calling it a European group because it's at a Central European convenient time. And that's going to be, because we don't have enough for just AS or advanced or whatever. It's going to be everybody mixed together, unfortunately, but hopefully we'll get enough people and we'll be able to break it up. But we'd love, when I put you into the base, I see this here. I would love to check you out for the Central European, and maybe you'll join us from there sometime. The other thing I wanted to say to you is that if you need a good urologist in San Diego, I've also put Michael Liss's number, his URL in there. He's at UCSD. He's also very AS centric. Philo AS, I don't know quite how you would say it, but he's pro AS. He's done lectures for us. If you can Google him on our website, and you can see him doing a lecture that he did for us on gut health. He's very, very good. He's a great doc, and if you're needing somebody who's not going to push you into treatment, Michael Liss is the guy for you. I think, moderators, would you agree?
Yes.
Yeah, absolutely. Absolutely.
Rick,
All right,
he's the guy I see at UCSD.
Oh, right. Okay. Well, he knows AnCan pretty well, Dr. Dan.
Yeah, he's a nice guy. I like him. He is younger, so he knows how to do transperineal biopsies.
Yeah.
But yeah, he's always pushing me for more biopsies. So.
Okay, well, push back. He says he doesn't, but that's good. I mean, so we hear it from both sides. That's good, you know.
I mean, that's a quick question I have. Is I don't like the biopsies. I have this I don't know, this might be a phobia, but I think it might actually spread it. And it does really impact me for about 2 to 3 weeks. The last time was quite some blood and hard to pee.
Well, I'll let the guys talk to you about alternatives and different ways to go. But I will tell you there is no evidence at all that it spreads it. It's a controversial topic that's been around for a long time, but there is just no evidence at all.
Thank you.
I put the link to Michael Liss's gut microbiome in the chat if you wanted to look that up, rather than having to go search for it. But yes, I agree with Rick. There is no evidence that has been a concern. But anyone else have questions for Lieven?
Well, Dan, I guess, Lieven, you said you had 29 biopsies at one time?
29 cores, the first one.
Well, yeah, that would make me a little fearful too. I mean, that's
where my Belgian urologist friend said, like, whoa, what's going on? They were hunting for something, but I don't know. It might just be a Singapore protocol. I'm not sure.
That is high. I mean, normally it's 12, and then if they target a particular or a couple of lesions, that number will go up. So that may be Singapore unique. I have no idea. Anyone else have any questions?
You might want to ask the physician if there's some type of pharmaceutical that you can take before you just, an anxiety type of med. I don't know. I myself get crazy in an MRI tube, so I got to take goofy pills before I go in. I take Xanax. I don't know how that interferes. I guess it would imagine perhaps if you were getting anesthetized or whatever, but perhaps there's something out there that can kind of relax you. Hopefully not to have a biopsy for a while. So hopefully it's a mute issue, but something to think about, because that is an anxiety thing, and that's not a good thing. Stress level goes up, and get nervous and jerky. There's nothing you can do about it if you feel that way about something like myself in an MRI. So anybody have any other questions for Lieven?
If I can add to that, I did my biopsy under propofol. There was no way I wanted to be awake for that. So I went into recovery. I waited. And that was it. It was done. I was out of there, and that was the end of that. So that's how I'm going to do mine. As far as the MRIs, I'll use like 10 milligrams of Valium. Put the heads on, the eye covers on, and I'm good.
You have any more questions for us, Lieven?
Yeah, maybe kind of one that I hadn't picked up on is kind of what to avoid before doing a PSA test, because my doctor doesn't give me any advice on that. And then I hear he's asking me to do it every 3 months. Is that the advice? Because in Belgium they were saying every 6 months.
Yeah, 3 to 6 months. It depends. 6 months is normal, but if you wanted to do every 3 months, that's up to you. But no hard exercise, especially riding a bike, but honestly, any hard exercise, no sexual activity for at least, they say 72 hours, but it probably doesn't hurt to extend that out a little bit. And you want to wait between, you want to wait at least 3 months, perhaps longer, after you've had a biopsy to have a PSA, because that's going to affect it as well. So anybody else want to add to that?
Well, the story I was going to tell is an interesting one that I didn't know anything about, but I came down with this nasty respiratory virus that's going around San Diego, and it hit like the day I was scheduled for my PSA, and I figured, it's not sex. So I went and had my PSA done, and it jumped from 8.3 to 10.3. And I said, that's got to be a mistake. So I waited a week and had it repeated, and it jumped to 13.3. So I got on Google and I found out that respiratory infections, especially COVID, but this wasn't COVID, my COVID test negative, but respiratory infections and other inflammatory systemic conditions can raise your PSA. I had no idea. So I got suckered on that one. And, I won't make that mistake again. But if any of you guys, it's wintertime, if you're coming down with some crappy thing, just put off your PSA for a week or two, and you'll save yourselves a lot of grief.
Good advice.
All right, Lieven, come back and visit us and stay up to date and keep us up to date on what's going on with you. And with that, I'm going to turn it over to Gary so we can get to the rest of the guys, because we've got quite a few guys that need time.
All righty. Thanks again, Lieven, and welcome. Brian, what do you got for us?
Okay. I'll be really quick because you guys always give me a lot of time. I wrote it out so I can just, it's just an update on where I'm at. I'm going to see my regular doctor at the VA, Seattle VA, this Friday. So it'll be the last doctor I have for a while. A week ago, I saw the urologist down there. I didn't get much, I didn't get a lot of answers there. Last Friday, I saw the urologist at the community care, the guy that did my aquablation. So I started bringing up some stuff that you guys talked about. Actually, you all said make sure you can have a conversation with the guy. We had a great conversation. I was kind of blown away. I said, have you heard of Epstein? He says, yeah, whatever. He said, thought he was 80 and he was retired. I said, no, this guy's in New York, man, and he reads slides. So he's going to send. He's already sent them because the hospital already called me today. The VA just has to okay it. He's also going to do biomarkers. Well, I said, have you heard of biomarkers? Well, of course he has. The VA told me they didn't do them, but he says, yeah, we can do like the Decipher score. I said, perfect, let's do it. So that's good progress. I learned all that from you guys. Thank you. That was community care. We're going to do a PSA in 3 months. If something shows up, if it's high, the last one was 5.2. Then we'll do the guided MRI with a fusion guided MRI. The only problem is they don't do the transperineal, they do the transrectal. So that's what I'm working on right now to see if I can get my doctor Friday to refer me to the Fred Hutch or the University of Washington in Seattle. That's my next goal, to see if I can get that done there, so it can be a perineal instead of the transrectal. Because I'm just going to tell them I don't want the antibiotics, less risk infection. Hits the anterior, the hard places to reach. So is there anything else you think I need to bring up with this? He's my regular primary care at the VA. He's either going to say yes or he'll say no. You just do the regular biopsy in Seattle, which is they don't do the MRI first because he said you had one a while back. Or should I? Or I can do the one through the community care, but they do the transrectal too. So that's kind of where I'm at.
Well, Brian, first I applaud you've listened well to the meetings. That's for sure. That's the first thing I want to say. You did a fine job of listening and writing down and keeping the context of what's going on in your particular case. So,
yes, sir.
Thumbs up to that for sure.
Thank you.
Okay. Well, we certainly you know all the ins and outs of the transperineal, so that's something you're going to have to go to bat for yourself.
Yeah.
And see if you can get them, see if you can get a community care place that will do it.
Yeah.
That's the one takeaway that I've got. And the last MRI was when?
It was in August.
August of 25?
Yes. And then I had my aquablation 3 months later.
Okay. In 11/20. Okay. Well, I don't know. I'll see what the other guys think about, and they're talking doing a biopsy without an MRI.
The Seattle VA is, because they said you just had an MRI that was normal, PIRADS 2. And they want to do it in 3 months.
I don't know what an aquablation would do, but wouldn't, they removed part of your prostate. So I would think getting another MRI would be important at this point.
He said you just had one in August.
Did he know about your aquablation 3 months later?
Yes. That was the first thing he asked me. Did you have that procedure done at the community care? I said, yes, I did.
So the MRI was after the aquablation?
Before, 3 months before. Yes.
Okay. Yeah. I would think an MRI would be important before that. Let's see what the other, got a couple of hands up. Let's see what they say.
I think so.
Dan, I've got to step out for a minute, so take over, will you?
Ray, you got your hand up?
Yes, I would think an MRI would be important to do before you had it. And also if you had a lesion in the midline anterior zone, it's much more accessible by a transperineal than it would be by a transrectal anyway. So depending on where it is, that might be a way to advocate to get the transperineal, depending on what zone it is, or what zones your lesions are. So I just wanted to point that out. And
Yeah, I think you're asking for another MRI is prudent because, as Hugh was kind of alluding to, I mean, you don't have a baseline of your prostate right now because you had aquablation. So everything, the geography is different than it was in your last MRI. So trying to compare, use your last one before the aquablation to guide that. I think that's, you're shooting in the blind, so to speak. Go ahead, Dr. Dan.
So I don't know, I must have missed something here. So Brian, you've had an MRI. You've got a PSA, you said was 5 something?
5.2. That was 3.5 months after the aquablation. They told me I got to wait.
So why are they pushing you to have a biopsy?
He's never had a biopsy.
They're not really pushing me, but I haven't really had a biopsy. The only biopsy, I've never really had one on my prostate, except for what they pulled out.
So how are you following AS if active surveillance if you've never had a biopsy? The only cancer was found on your aquablation?
Yes. Yes, 3 + 4, 10% was 4.
Well, then the VA can be great, but it can also be a pain, and you know that. I mean, you got to advocate for yourself. The kind of biopsy they want to do is not a targeted biopsy anyway. They want to know where you might have cancer and how many cores are positive. So I'm not sure that you need to have an MRI. They're going to do a systematic 12 or 13 core biopsy. Let's just do it then, but yeah, I agree. It's got to be transperineal because, man, you don't want to end up, ask Andy, you don't want to end up in the ICU with E. coli sepsis.
Well, the community care will do they'll do the guided MRI biopsy in 6 months from now. But they'll use the MRI. So you're saying I don't need an MRI? Because some people say yes, some people say no.
Well, they're going to do a systematic and they're going to do the 12 cores, no matter,
Right.
So if they know they're going to do that, and we know you already have cancer, then I don't know that the MRI is going to add a lot.
They shouldn't do that 12 core, Dr. Dan. They shouldn't do it.
How does he compare himself to everybody else here? How does he know how many cores he's positive?
He has to get proper treatment. Proper treatment is he gets an MRI and hopefully he gets a transperineal, and he gets a proper guided biopsy, just like anybody else. For the VA to go in and do one of these 12 core sections like I had 17 years ago, that's not the treatment, and the bloody VA knows it. And if you advocate, you'll get what you need, because they just try to get everybody through as cheap as they can, but they're not supposed to do it. We don't recommend a non-fusion biopsy at any time. Now, I would have said, okay, within 6 months with a guy that has fairly not very active prostate cancer, fine. But the guys bring up a very good point. You have different geography there. And because of the different geography, you need a new MRI. And that MRI should be used to guide, hopefully, a transperineal, if not a transrectal. But you should be able to get a transperineal under the
Community care.
community cancer guidelines.
Yeah.
Community cancer is not just about sending you to somebody in the community. It's about sending you to somebody in the community who doesn't do what they do. That's the point. Now, we've got
Right.
a bunch
Right.
of vets in here. Do we have any vets in here who have VA experience? Colonel, go ahead.
I agree with what you said. They're gonna do whatever is prudent to get you through. Although, generally speaking, if you can articulate what it is that you want and need, they're supportive. My experience is once you get in the VA, the people that are there are supportive and helpful. But as long as you can articulate it, and Brian, sounds like you're able to do that. And I think you can make the case. You can make the case that you need an MRI.
I'm going to do. Okay. Yeah, I'm in the VA. They actually did open heart surgery at the Seattle VA and gave me a heart valve a couple of years ago. So I mean, I'm in sync lock with the VAs. They've been great. I mean, I got no complaints whatsoever with the Seattle VA. It's been.
Brian, you have an artificial heart valve?
Yes.
Oh man, you cannot have a transrectal biopsy. No freaking way.
Oh wow.
Yeah,
thank you.
That's out of the question.
There's your reason.
There you go. You got
there it
everything
is.
you need now.
That's it.
Okay, that's all I needed to hear. Thank you guys. I'll
Sure,
let you know how it goes.
You're locked and loaded. It's like a double barrel shotgun, and you got the 2 slugs in there now, and you just cocked it back. You're good to go, bro.
Okay,
I have
me.
I have a question, if I may. You're talking about community treatment, and you're talking about VA treatment. So under VA, just so I'm clear.
Andy, let us cut you off. This is a technical term for a type of treatment and access to a type of treatment within the VA. This is not community treatment as what you're saying. There are new regulations and laws in the VA that allow you to go outside of the VA for what they call community care. It can be at a community center or it can be at a center of excellence, but that's just the terminology that they use for going outside of the VA.
So just so I'm clear, is it separate from Medicare because it's VA?
Yes. Got nothing to do with Medicare.
Okay, so Medicare is not involved. You can't do both.
No.
Okay.
No.
Just wanted to be clear. Thank you.
I think I'm good, guys. I don't want to take any more time. You guys have always helped me out.
Okay, and Gary, would you say that was priceless, what we just gave him?
That was priceless.
You've got everything you need. That's it. It was
that
definitely
that
priceless information.
That was Dan, right? Was that Dan?
Yep, Dr. Dan in San Diego. He's the man. Yep, absolutely.
All right.
But what's also important, Brian, is that you share everything so that somebody picked it up.
Yes. All right. Thank you, guys. Thank you. I love this stuff. I've been binge watching these videos.
Okay. Well, good luck. Okay. Good luck with your next meeting. We'll see you next week.
Okay. Thank you. I'll be there. Right. I'll be there. Bye-bye.
Okay. All right,
Thank
Mitch, you got something about, I tell you what, you were going to talk about what, okay.
And we're getting that from you, Dan Gifford.
I got some random phone call.
Okay.
Oh, okay.
Right. Mitch, you wanted to talk about what this evening?
Okay, I just have a quick question about my pathology read from Dr. Epstein, and then I also had some information on BPH.
Okay, well, maybe we're going to delay the BPH information either till later tonight or because I'm a little curious about getting through the list. But tell us about your Dr. Epstein question.
So quickly, I got a read from Dr. Epstein, and it confirmed my local pathology read, came back 3+3. My question is, both the local pathologist and Dr. Epstein find 2 cores at 30% and one at 40%. I haven't talked to Dr. Epstein yet, but I will call him and ask him this question. But how significant is that as an indicator? Is that a size indicator, or should I be concerned about that? Or does that mean that they just happened to sample a spot that was, gave a better yield? I'm not sure how to interpret that meaning.
Number one, are we talking about 3+3 cores?
Yeah, they're all 3+3,
Okay.
but there's just more percentage, I guess. 30% involvement in one core and 40% in another. The others are like 5 and 10%. So is that something that needs to be discussed, or is that?
Well, number one, 3+3 Gleason 6 is not of, it's a grade group 1 and pretty.
No, I realize
pretty
that.
low
I'm
risk.
just wondering. I'm sorry.
No, we have some people, Mitch, that are high volume Gleason 6, 11 out of 12 cores. Some of them in greater numbers than you have. The key here is 3+3, and then what you got to do is you keep your eyes open and do the right thing. Do the PSA, get the MRI annually, get the biopsies as scheduled, unless there's a drastic change in your PSA. Don't go looking for trouble if it's not there. That would be my advice. Perhaps Dr. Epstein will concur, but kind of like Dr. Dan, if it ain't broke, don't fix it. So
I agree. Thank you very much.
That basically would be the take.
Harry, I think we can touch on, I think the percentage though is that they're saying in that core, it was a percentage of that core that had like Gleason 3+3, 40% of that core was cancerous. Okay, so it is more volume than if it was 5%. The good news is it's a Gleason 6.
Clinically, that doesn't change AS at all, is what I'm hearing.
No, not at all.
Thank you.
No,
Thank you.
It's all good. Okay.
Yep.
And we'll get back to your insight on BPH, Mitch. I just want to make sure that we get to the other guys. Okay.
Yeah, no problem.
Okay, Bill, you're up.
Thank you for taking the time to listen to my plight. I'm 72 years young, and I was diagnosed in 2017 with with 4 3+3s back then. In 2020, had a repeat biopsy, and at which point 5 3+3s were detected. Again, in 2021, we had a MRI guided biopsy. We had 6 positive cores. 3 of them were 3+3s, and 3 of them were 3+4s. And it was also looked at by Epstein in 2021 as well. And he pretty much concurred with the original diagnostics. I've been having MRIs every year since 2021, and the doctor I was working with retired. He turned me on to a new urologist who ordered an MRI and a biopsy here in December and January, and the biopsy was last week, and they came up with 4 3+3s and 3 3+4s with 10% patent 4 in 2 of the cores, and 1 of the cores patent 4 was 5%.
Okay, Bill.
So Bill, I was trying to keep score here, but if you went to some of these doctors that like to remove your prostate, you would have had your prostate out 3 times by now.
But the first urologist that I spoke with, with the 4 3+3s, he wanted to do it the next day.
Exactly.
And when I met with him 2 years later, he says, "I can't believe we still haven't had you on the table."
Tell him it's not going to happen. The next time you see
Bill,
him.
you're a perfect example here for AS. I mean, been going on this since 2017. Is that what you said?
Correct.
Yeah. And so what's the current diagnosis? Just to keep going here?
Well, I'm meeting with the urologist on Tuesday of next week to review the results of the pathology stuff, to hear what his plight is. This will be the first time I'll hear him give me the surgeon pitch, you know.
Yeah. Yeah.
But and I don't have a warm and fuzzy feeling that he is AS centric. So if there's a AS centric doc in the Boston area that you can recommend, I'll look for that in the chat. But I am very much trying to stay on the AS team, and I've been, it's 8.5 years I've been doing this AS piece, and the Gleason scores haven't changed one iota since 2021 to now.
Yeah.
What about PSAs, Bill?
PSAs, it's always been rising. The most recent one was in October of 25, and it was a 12.98. And 3 months before that, it was an 8.96, 8.7 before that, 8.2, 7.15, and it falls back slightly. But the most recent one was 12.98, and the PSA volume is at 85 right now, and it had been at 76.
So you're getting older and your prostate's getting bigger, and so PSA is rising a bit. I mean, that's what he's going to probably center on is your rising PSA.
Yeah.
Bill, are you going to send this latest 1225 pathology to Epstein?
Oh yeah, I got the form right here all ready to hand to him when I go into the office, because it looks like on the uropathology website that you have to have the doctor request this.
I'm not familiar with that, but if that's what it indicates, yeah, then let your doc do it.
Yeah, that's what it is.
This is Epstein's form.
Okay.
Yeah, but push come to shove, he will get it taken care of. If your doc pushes back, you can get in contact with his office and they'll ask for it. So
In
you can
my
get
case,
around.
I had to call pathology in Delray to find out what they needed to feed it back to the doctor so the doctor's office could get it right, and they finally sent it out. So you may want to try to stay on top of it as much as you can.
Mitch, you got a question?
Yeah, the first time I got a opinion from Dr. Epstein, I sent it directly as a patient. I asked him if I could do that. He said, sure, you can do that. The second time, and I took it into the path lab and handed him the form that Bill is showing, and they took it and sent it. But apparently they had a change of rules, and this time round it had to go through the doctor's office. So I guess it just depends on your jurisdiction and what their operating procedure is, but you can try walking it through without going through the doctor's office and see if it works.
Well, the last time out with Epstein, it was he was at Hopkins then, and I guess I could hand it right to them that way. But now that he's with this Advanced Uropathology enterprise, they have this set up.
They took it directly, Bill. The same uropathology group took it directly from me.
These slides will get to Epstein.
Yep, that's the key. Rick, you got something for Bill? Can't hear you, Rick.
Mute.
Can't hear you, Rick.
You're looking for an AS-centric doc in the Boston area. We'd suggest Adam Kibble at Dana-Farber. It's in the chat window. You don't have to write it down. Just click on the link. I put it already in the chat window already. His name was given to us by one of our advisory board members who's at Dana-Farber as a surgical oncologist who favors active surveillance. And in fact, his name came up yesterday in the high risk group with somebody who needs treatment and was seeing him today as a doc who recommends radiation, a surgeon who recommends radiation when appropriate. So I think he should be a good guy.
Excellent.
Just a quick reminder, gentlemen, everything in the chat, make sure that before we say goodnight, you put it down to your files or download it or whatever you do that way. I work off an iPad, so I can't do that, but just a reminder. Anything else we can do for you, Bill?
No, just the best news I heard was I'm a perfect candidate for AS and to fight back on these guys.
Absolutely, absolutely. That's for sure. And you're doing
Keep your
all the right
plumbing where
stuff.
it's
I mean,
at.
you're staying on top of it, and you sending your pathology. Let's see what Dr. Epstein says.
I guess the only question I have is the difference between 3+ floor. What's the threshold for low risk versus intermediate risk?
Well, especially, as my doctor, when I had a 3+4, I said, "Aren't you concerned?" He said, "Well, the 4 is in the right direction. The second number, not the first number."
Right.
So, Dan, take it
Okay,
from
so
here.
low risk is 3+3. 3+4 is low intermediate risk, or what do they call it? Or
Favorable intermediate.
Favorable, thank you, favorable intermediate risk. So you're no longer low risk if you have a 4 in your number.
Right, so I'm favorable.
Yeah, the NCCN guidelines would call 3+3 very low risk, but you also have to have a PSA less than 10. Now your PSA has crept up a bit. Before that, it had been hanging out in the 8 range. Did anything change when you had your last PSA done?
No.
Yeah, might be worth repeating, because that probably does take you out of a very low risk and puts you into low risk. But if the oncologist that Rick recommended will be familiar with all that, so.
Gotcha.
Okay, Dan, you're up next.
Thank you, gentlemen.
I asked I'll talk to Rick after this is over about bullying my way in to see
Dr. Carroll.
to see Dr. Carroll.
I can answer it very quickly. He's not taking any new patients. At the same time, I'd be happy to drop him a line tomorrow. And if you can just send me your history, because I don't keep notes on the AS people, or Gary can send me your history. Somebody send me your history, and I'll write to Peter and I'll ask him as a favor for us at AnCan, would he mind speaking to you? He has been an absolute champ about talking to AnCan people that carry a BRCA mutation. And he's really treated them well. And so there's a good chance, but I can't guarantee it anymore because he's really trying to cut back his practice.
Yeah, no, I get it. And I sent them all that stuff, and then they wanted copies of I sent them everything, and then now they're actually sending to UCSD to get the originals. I mean, I can tell that I'm going to get the runaround. So anything you can say would be great, because as I said, he does seem to have an interest in this field of.
No, he does.
And
he does. But just send me, you need to send rd@ancan.org. I'll put it in the chat window, but you just need to send me, keep it short, please. Just need to send me what's been done. So, because I don't want him spinning his wheels.
Okay, no, that's fine. I'll send it to you. Thanks.
Something else, Dan?
Nope, that's it. I told you about my little fairy tale with the upper respiratory infection, just as a cautionary note. If anybody happens to have a PSA scheduled when they don't feel when they're under the weather, it's not a good idea.
Yeah, we're sort of aware of that, and there is some research that from COVID times, and during COVID we were well aware of it. Gary will remember, and you will remember that we used to tell people, be careful because COVID can affect your PSA. But also the fact that other inflammatory conditions affect your PSA too. We sort of knew about it, but thank you for bringing it up, because I think it's really important.
Go ahead.
And it's great also that we're bringing it up on a recording. That's great.
Alan, you got your hand up quick?
Just to reiterate, I had the flu right before my PSA was scheduled for December. I reached out to MSK. They said delay your PSA to the last possible day before you're due to see the doctor. My PSA was very slightly higher than normal. They considered it in range, but same thing that Dan's saying, delay it, delay it, delay it.
I wonder if that would be a good reason to, I was just at the VA and they talked me into an RSV vaccine. Of course, I'm 75, which
Yes, a good idea.
I have no COPD or upper respiratory distress, but perhaps for older guys that are on AS, maybe the RSV thing, if you can tolerate vaccines, is not a bad way to go.
You know, I would put, Gary, that's a great, I would put those preventative measures right up there with getting PSAs and colonoscopies. You know, we used to have a saying in the hospital, pneumonia is the old man's friend. I mean, you got to take care of your lungs, because if you get sick, it's one of the common ways that guys end up going out the back door instead of the front door. So get your pneumococcal vaccine, get your RSV vaccine, get your COVID vaccine. And anybody tells you otherwise, just tell them to get lost.
Okay. All right. Dean, I see you've got your hand up. You joined us late. Sorry about that. We've got one gentleman ahead of you before that was here earlier. Carl, we've got about, well, it's 9:30. Do you think we can help you out in 5 or 10 minutes? Or would you like to be first up next week?
No, I'd rather quickly address my issues, because I think it literally is going to just take 2-3 minutes.
Okay, go ahead, Carl.
All right, I am with the VA, and I'm part of the PACT Act. So I'm getting disability from the VA, and I am in active surveillance, and I want to make sure from the quorum that I do everything to stay in a good standing with the VA regarding my active surveillance. From your experience, what do I need to do on an annual basis with the VA to keep my active surveillance going?
Well, to tell you the truth, someone that would know the exact, if there is a criteria, in other words, that the VA would be Jim Marshall with our VA group.
Okay.
The basic things for us on the screen are basically MRIs once a year, PSAs every six months. Some people go every 3 months, but basically, I did a show of hands last week. It was basically every 6 months, I think, was the majority. And of course, if you're getting treatment, are you getting treatment from the VA urological department?
No, I'm not. I'm doing it via Medicare, via my regular urologist.
Okay.
So I'm in the same boat, Carl. So I get my care through Medicare, but I maintain a primary care manager at the VA. So make your appointments. You got to have an appointment once a year. I get try to get my blood tests through them as well, and just stay in contact with your PCM, with your care group there. And what Jim will tell you is active surveillance is a form of treatment. So you may have to go through and reiterate that to them, but as long as you're getting your blood tests, you're getting your MRIs, and let them know that information, they're usually pretty good about it. I'm not sure about Virginia. Jim Marshall would be the great one to talk to.
All right,
and
I will do that.
Next Tuesday evening.
Carl, I do the same thing as Dan does. I have Medicare and a supplemental plan. I go to the Mayo Clinic in Jacksonville, just as he does. But I go to the VA once a year, do blood work before, and she knows that it's a lady. She knows that I'm taking care of my cancer on the outside. I don't really tell her what I've done. I don't talk to her about numbers. She doesn't inquire. I have all that information if I need it. But there is, I mean, Dan almost, I concur. That's all you really have to do to stay in the VA system, is make that once a year annual visit. And when your PSA comes over 4, they're going to highlight it and say hi. It's going to have an H rather. And then you're going to tell them, well, I get cared for on the outside. And that takes care of it.
Perfect. Thank you very
Okay.
much. That's all I have. I yield my time to the next contestant.
Hold on a minute, Carl. You're not getting the reminders for the veterans groups right now. So I am going to put you on for the 2 veterans groups that we have.
I appreciate that.
What'll happen, the benefits group is twice a month, the first and third Tuesdays of each month, not in this room, it's in the other room, but it's at the same time as this group, but it's in the Schmear room. And I would definitely say attend there. You'll find a bunch of guys who are in the same boat as you. And then we have another veterans group as well, which is just a discussion group for vets. And you'll get that too. So you're good to go.
Well, Rick, that sounds excellent. Thank you very much for connecting me to those groups. I was looking for something like that, and you're presenting it to me without even asking for it. I am very, very thankful.
Well, we're glad to have you here and hope to see you in the future.
All right. Thank you very much.
You're welcome. Dean, it has become the witching hour. Have you been with us before, sir? Dean,
Yes,
you're muted.
Yeah, can you hear me now?
Yeah.
Yeah, last week must be my first time.
Okay. All right.
So if I could just ask one question, and then I wanted to fill you in kind of on what's happened in this past week. But my question would be, I'm having trouble finding a good doctor. Does Rick or anybody have? I'm in Denver, Colorado. Does anybody have a recommendation for somebody in my area?
You know, Denver's always a challenge, always. The answer is I think so. I need to look because I can't remember. I don't know who to be honest, well, maybe it'll jog my mind, but I don't know who the AS-centric urologists are at Anschutz.
Okay.
But I'm going to take a quick look and see if I do remember. We don't have any Denver people who are on right now. This may be a question we've got to ask Howard. But let me.
Who was the guy from Denver always on? Mike Wynn, right?
Mike Wynn.
Oh,
yeah.
Mike Wynn. He would know.
Yeah,
Yes.
Mike Wynn would know. Yep.
Mike Wynn. Great. Good catch. Hugh, can you drop Mike Wynn a line and ask him?
Yeah. If you give me his email, I would do
Yes.
that. I don't think
Okay. I'll give you his email, or Gary probably has his email in there. But I'll give it to you. And yes, we can definitely check with Mike Wynn because he would definitely know. I am going to look whilst you talk about your other stuff. I'm going to look. And
I don't want to, I'll save all my kind of wrap up or what happened till next week. But just if I could ask one more question to Dr. Dan. Brian had said he had open heart surgery and a valve replaced. I've had open heart surgery and a valve repaired. Am I in the same category with never do a transrectal?
What valve did you have and what kind of repair?
It was a mitral valve repair. I was at Cleveland Clinic, and all he did, my understanding is he explained it to me like that valve is like a parachute, and your parachute has those strings, if you will, and he just replaced some of those.
The chordae tentina, yeah.
Yeah, and I'm not on. The only thing I'm taking is a baby aspirin and a very low dose of metoprolol.
Did they do a Carpentier ring or just repair the chordae?
I have a ring.
You have a ring, okay. But all this, yeah. I mean, do they have you take antibiotics before dental work?
I do.
Yeah. So, I mean, your risk would be pretty low compared to having an artificial valve, but still, I just don't see any reason why in 2026 anybody would want to have a transrectal biopsy.
Yeah, no, and I was just curious for my own benefit, but I'm transperineal, and that's what I'm looking for right now. So
good. Okay.
All right. Thank you, guys. I apologize for taking up so much time at the end.
No, you didn't take time at all. I'm still looking for the GU doctors. I put Mike Wynn's email address for Hugh in the chat window. If you come back next week, we'll maybe have an answer for you.
Okay. Thank you so much. I appreciate the search here.
Rick, I have a question. Does it do any good for people to use the NCI website and look for centers of excellence, or is that just hit or miss?
Well, it's kind of hit or miss because not all centers of excellence are born equal. Centers of excellence are not just NCI, they're also NCCN. And just by going to a NCI or NCCN, you may not get somebody who's proactive surveillance. So we do our best to try and send people to doctors who we know favor active surveillance. Now, by and large, that's usually not in the community, although that's not always true. There are community doctors who do active surveillance. They're happy to do it. They like it. They push it. But the majority are not great. At centers of excellence, you've got more chance of finding, but you have some centers of excellence where Northwestern in Chicago, NCCN Hospital, and that urology group are a bunch of cutters. They'll slice you up as soon as look at you. It's hard to find a urological oncologist at Northwestern who favors active surveillance. So it's just experience, Dr. Dan.
Okay, gentlemen, that about wraps it up. Dan, I won't be here next week, so if you'd make a note, please. Mitch wanted to talk a little bit about that BPH stuff. So if we give him some time next week on the 18th, I won't be here. So
I'm gonna be here either.
Okay. Ray,
I'll be gone.
here, or you? Just make yourself a little note to give Mitch some time in the beginning.
Actually, I won't be here next. Sorry, Gary. I won't be here next week either. I'll be in Chicago.
Oh well, there you go. So forget
Catch it
about
later.
Mitch till we see him again, and he can raise his hand, and we'll take care of him. Not a problem. Okay, Mitch, just trying to do you right, but that's okay.
Well, hold on a minute. I tell you what, if it's BPH and this is being recorded, how much time do you need? I mean, if it's short, let's just talk about it and then we get it on the recording and then that's
5 minutes.
Okay, can you make that 3?
I can make that 3.
Okay, go ahead.
Okay, so I did some research. I checked the guidelines, American Urological Association, European, Canadian, UK, and Japan, as well as going to the up-to-date subscription review service. And here's what I found out. I'm just going to send some little clinical pearls. Aquablation preserves erectile dysfunction and ejaculatory function in nearly 100% and 90% respectively of patients. 5-year treatment rates are low, 6% at 5 years. Also regarding aquablation, there was a study of larger prostates, 80 to 150 in size, that showed that 5-year follow-up, only 3% of those patients required surgical retreatment. The number of passes may be important on aquablation. A study showed that a single pass ablation was not as effective as 2 or more passes during the procedure. Okay, there are still concerns about management of bleeding and bladder neck cautery with aquablation. Aquablation is technically more precise and easier to learn than many other surgical procedures. Moving on to the second category, prostatic arterial embolization, or PAE. There's a lack of substantial evidence in recommending PAE over more widely available procedures. There is evidence of short-term benefit compared to observation in a select patient population, while other techniques specifically target critical areas in the bladder outlet obstruction. PAE impacts the entire prostate, without exerting any focused and controlled action on the specific obstruction. This may explain the higher clinical failure rate compared with more traditional methods and the commonly observed complications such as acute urinary retention in almost 26% of cases. Another problem with it is non-targeted embolization because it's difficult to identify some of the smaller arteries, and some of the little particles they inject can go into the bladder, seminal vesicles, or elsewhere in the prostate and cause complications, including urethral burning, nausea, vomiting, which have been called post-PAE syndrome. And finally, according to a non-inferiority trial, 21% of patients who initially had PAE underwent TURP procedures within 2 years of that procedure. One more point, gentlemen. There's a concern about the radiation exposure with PAE. One study calculated that getting a prostate artery embolization procedure with the fluoroscopy would take 5 days off your life. So that's what I got.
In conclusion, I say PAE thumbs down. That's what I
what
got
it sounds like. Well, there's specific patient clients that could benefit from PAE, but generally it sounds like aquablation is it's more durable, less side effects. It is a hospital procedure, but I mean that's what the evidence shows.
Okay. Well, thank you so much. And as us being the group, and the more we learn about that, I know Mike up in Alaska had the aquablation done. We had a couple of guys that have had it done. So if in turn someone is contemplating that procedure, here again, peer-supported groups are the best. Ours is absolutely the best. And you can find out everybody's individual experience as to what's going on, as well as, somebody like Mitch coming up with all the clinical data. So with that, gentlemen, we're going to say good night. I won't see you next week, but I'll be back in the summer. We'll be here next week. That's all that counts. So be sure to join us. And moderator's going to stick around for a minute.
Sure.
Okay. Well, good night, gentlemen. Take care. Everybody be safe.
Good night. Thanks very much.
Good night. Safe travels, Mitch. I was talking to Howard today.
There's some
He's
guys
doing
that
well
needed a little help.
and says hello.
No, we're good. We're good. Everybody got up.
Good job tonight, guys. So, Gary, you're not here next week. Dan, you're not here next week.
No, I'm on an airplane next week. This time.
Okay. And Phil, Phil, are you here next week? Mute.
I am.
Okay. And Ray, you're here next week?
Yes.
You're going to be there next week?
Yeah, I'm in, and then I'm out for 3 weeks, I think. So yeah, I'll be here next week.
Okay.
So
Eric
we'll
may
get
be
the
here
correspondence. We'll handle it next week. So good job, guys.
Okay. All right.
Ray, was that guy Strauss? Do we know anything about him?
The only I did a quick search, which is why I sent it to you, because I didn't want to, but he evidently is at AnCan, and he did publish an article. I think he did publish an article on active surveillance. He said that active surveillance for prostate cancer, focal therapy, and localized renal cell. He completed his urologic fellowship oncology as well. 2024. I don't know if he's really, but he's evidently he published. I mean, they said that he's the most explicit for active surveillance as far as his interest. I guess he's got, but
their website is not easy to work with.
Says those are his research interests. So, but he seems pretty young too, I guess. So, I don't know.
Okay, guys.
Right, Gary.
I'm back. Sorry, my internet just dropped. Their website's difficult to work with. If I can find a list of the doctors, which is not easy to do, they're urologists, it'll remind me. But I would say dropping a line to Mike Wynn is really a very smart idea. And
Already done it.
thank you so much.
So,
and if I find somebody, I'll send the name to you too, Hugh. So you've got the names for him.
Okay.
So.
All righty, gentlemen, I'm out. I've got to run. So.
Okay, man. See you later, Gary.
Take care. Take care.
All right. Take
night.
care.
Good
Good night, everybody. Thank you so much. Thank you. Thank you.
Thanks.